Well, hi there. My name's Simon Rice, and welcome to this webinar on assessing depression in men. Thanks very much to the folks at UBC and the Men's Depression and Suicide Network for inviting me over. Really looking forward to my time here, and keen to talk to the audience today about some work I've been doing in the field of men's depression. And this is something that I've been working on really since my PhD. I'm a clinical psychologist and started off this work back in about 2008 and continue to work in this space. I find it pretty interesting. So I'll, in terms of the presentation in general, I'll just give a bit of a brief overview about some background factors related to men and depression, talk about the assessment of depression in men and some particular scales that are available now, and then just give a bit of a summary of kind of where things are up to and next steps. So in terms of a starting point, this is Australian data, but it could really be data from anywhere in most Western countries around the world, that we know men are more likely, much more likely to die by suicide than our women. And these rates are, as I said, really pervasive, and this is one of the things that's really stimulated this line of work, that how can we better capture and better assess and better support men who may be at risk of suicide, so that they're not, and society and their families and communities are not adversely impacted by that tragic event. By looking at some of the qualitative data that we've had for some time now, when men talk about being depressed in their own words, they use some consistent terms, and so some of these have come up in recent studies, that feeling like it's not possible for them to feel feelings of vulnerability, that they're more likely to use substances, whether that's alcohol or drugs. They're much more likely to avoid help seeking in some of those times, and that there's a bit of a tendency to kind of fall into other symptom traps like overwork and aggression, and sometimes irritability and anger. And so some of these studies are kind of a bit of the starting point for this work, and I'll pick up on some of these threads later when we talk about some of the subdomains that we might want to consider when we come to assessing depression in men. Thinking broadly though, there's something about being a man that kind of indicates or suggests a need for there to be a bit of a social proof about demonstrating manliness or masculinity. And some great papers by researcher Vandello around this theme of precarious manhood. And essentially, in these series of studies that were done, it was concluded that whereas womanhood is really the result of something that's natural and permanent and biological, manhood is often something that needs to be earned and proved, and therefore can potentially be lost. And so this kind of proving manhood through public kind of displays is kind of this notion, so that Vandello's work showed that in a series of experiments that were replicated, that when there were these challenges to this kind of notion of masculinity and a man's manhood, these really kind of incited displays that really needed to prove themselves in various ways. And I think that's an important marker when it comes to things like depression and mental health in general for men, that it's not necessarily something that comes easy from a help-seeking perspective. In terms of some of the kind of theoretical literature, we know that males and females acquire lots of gendered attitudes, cultural norms and behaviours and ideologies around what's appropriate in terms of gender-based behaviours. And we also know that certainly within dominant Western kind of societies, that there's a strong emphasis on traits around masculinity of stoicism and competitiveness and inexpressiveness. And I think work over the last almost 2 decades now has shown that these are factors that have a strong impact on the way in which symptoms can be expressed, but also the way in which help seeking can be sought or not sought. And Anne-Marie Lemkula's work has really shown that some of these factors can be really powerful barriers to the help seeking process for men. On the slide, on this particular slide, there are some images of relatively recent help-seeking campaigns that have been run at national levels in the United States, in Australia, and the United Kingdom around what depression in men kind of shows like and can feel like. And kind of borrowing back on some of those terms that was presented in the qualitative slide earlier, there are themes here around men feeling angry or irritable, not being able to kind of necessarily be around others, or feeling like they need to engage in lots of drinking and alcohol and things like that, or losing control. And I think the interesting point is that these are not the kind of behaviours, symptoms that are considered in current diagnostic checklists. So if we think about the DSM or the ICD, so we've kind of got this strange perspective going on now, where we've got these national kind of mental health campaigns advocating this is what depression looks like in men, but we've got our diagnostic system that doesn't necessarily align with that. One of the first groups to really tackle this problem were in Sweden, and they developed the Gotland Male Depression Scale and published this in 2002. And this is the paper that really piqued my interest in the field. And so I started to read it and got a bit of a sense of what some of the items were that were being assessed by the Gotland Male Depression Scale. And this is the most widely used measure of male depression in the field to date. There are a couple more, and I'll talk about those in a moment, but this was the first, and I think by consequence of it being the first, it's been the most widely disseminated. But as I started to read through some of the items, I kind of got a sense that maybe psychometrically there might be some problems going on here. And if I can just bring your attention to question 11 here that's on the screen. So this asks participants to rate this particular question. So during the past month, have you been engaging in overconsumption of alcohol and pills in order to achieve a calming and relaxing effect, being hyperactive or blowing off steam by working hard and restlessly, jogging or other exercises, under or overeating? So on a 4-point scale, if you ticked extremely so to that item, it's really hard to know what you're actually endorsing, because there's about 6 or 7 different constructs going on there. So this, while I would say the Gotland Male Depression Scale has been really important in stimulating and generating interest in the assessment of depression in the peer-reviewed literature, I think it's also really limited. And so the first study that I kind of undertook in my PhD was, well, to test out some of the statistical validity underlying the scale. And lo and behold, found that from a confirmatory factor analysis perspective, that the two-factor model was a really poor fit to the data. And then it also ran a number of subsequent models, and they were also really poor fits to the data. So the conclusion being that substantial modification is really needed to that scale. I hinted before that there are other measures of male depression available, and another one to draw your attention to is the Masculine Depression Scale, developed by Magevsevich and Addis, Clark University. And I think there are lots of benefits about this scale, but one of the things that limits its use is that it's fairly long. So it's 44 items in total, and within those 44 items, it only has 2 different subscales, an internalising and an externalising. So based on this work, I was interested to really kind of try and stimulate a bit more research and try and push the field by developing a scale that was more multidimensional in its nature, but also a bit briefer. So there was a greater likelihood that it could be used in primary care settings. One of the strongest pieces of evidence that depression might be differently in men comes from a 2013 paper that was published in JAMA Psychiatry by Lisa Martin. And this was interesting because it was the first kind of really large-scale epidemiologically robust study that started to kind of consider that, well, if we build in some kind of more alternative ways of thinking about depression in men, does that actually change the rates of depression diagnosis? And lo and behold, this study found that the gender differences in diagnosis of depression disappeared when you built in things like irritability and anger into diagnostic decision making. And so this paper's already become quite a landmark paper in the field, and I think, you know, this is the kind of work that we need to show, and we need this kind of rigour around the work that we're doing. So coming back to the scale that I developed, which was the Male Depression Risk Scale, or the MDRS for short, I followed a very structured development in putting the scale together, and so really there was across 8 different steps, and within that there was a focus on really evaluating the items and optimising the scale length, done with studies of both males and females. And so we'll talk in a bit more depth about the scale itself now. And so in the first iteration of the scale, so I used exploratory factor analysis to develop it. So some of this is getting quite technical, but I'll try and make it as applicable as possible. But basically, what I developed was a large pool of items, so about 80 items, put them out to expert review, and then went through a rigorous process of whittling down those items, because I knew that most of them, the vast majority of them, wouldn't necessarily be, high loading or genuinely reflective items of the constructs that I was keen to measure. But what I found in that first analysis was that there were 7 different subscales. And so the first one was emotional suppression, which sometimes I refer to as being distress, but kind of tapping into a similar dimension of kind of trying to ignore feeling, upset, and but feeling upset being a core domain there. Also, drug use and alcohol use, anger and aggression, somatic symptoms and risk-taking. And then there was also, at this version of the scale, a 2-item subscale for interest in sex. But really, I was concerned because it doesn't make a lot of sense to have a 2-item subscale within a broader scale. And I wasn't convinced that was going to make it through to the next iteration of the scale. So initially using an exploratory component to work out what the scale was, and then at the next level using a confirmatory set of statistics. And so firmly from a kind of a scale reliability perspective, you can see that the male alpha and the female alpha values are reasonably good there, with the exception of a couple of the scales for females in particular. So in total, at the next iteration of the scale, it ended up being a 22-item scale, and then it was assessing 6 different symptom domains, and this is the scale items in its entirety. And so one of the other factors that I was keen was to make the items as brief as possible and use a fairly basic level of English, so that wasn't a high degree of complexity. And for the most part, each item really just focusing on one kind of core domain. And in terms of the stats that were done, so using a confirmatory factor analysis process, so once again it's getting a little bit technical, but the fit indices, which is what you come out with when you do CFA analyses, effectively you're looking at the CFI, so there are values down here, CFI, TLI, SRMR and the RMSEA values. They've got key criteria that you're trying to achieve, and typically the CFI and the TLI values in large samples, you're aiming to get about 0.95 or above. And so it wasn't quite there, but it was above the 0.90 level, which is typically considered reasonably good for smaller samples. And in this particular sample, I had 258 males. So I was kind of confident that, from a statistical kind of validation model, that the scale was looking pretty reasonable and not in too bad a shape, and certainly much more robust than the Gotland scale, which the confirmatory factor analysis inventories were much lower for the Gotland scale. So then after that, I was also keen to get a bit of a sense of how the scale looked longitudinally over time. So I'll go to that next slide now. So I was looking at the difference across effectively 12 weeks, but I think the mean time elapsed between time 1 and time 2 data collection was actually 15 weeks. But what I was keen to see was, well, how static are the relationships between the variables, and so the correlations between time 1 and time 2. And you can see that all of the correlations, well, they're significant in the moderate to strong range, which is saying that these are items or constructs that are relatively stable across time. And once again, you can see in the first green box there that the subscale reliabilities, at least for the total score, were really good overall. The risk-taking scale for females was a little bit on the low side, so I think that's really suggestive that risk-taking is probably more of a robust construct for males, or at least the items that were assessing it in this study were. The other key point about this slide is that the MDRS was really quite robust in relation to the PHQ9. So that's a widely used measure of depression, and essentially it just maps onto the 9 symptoms for major depressive disorder from the DSM. And it's become a little bit of a gold standard, I guess, self-report measure of depression. And I was pleased to see that it was mapping onto that really quite well. So then I was keen to also have a look at how the maldepression risk scale maps onto stressful life events, because effectively, if I kind of trying to get a bit of a sense of, well, are there trajectories of people who might be at risk of higher scores, and if you're thinking from a stress diathesis kind of model around depression, if you're experiencing greater risk factors and have poorer coping, you're probably more likely to be at risk. So I was interested to get a bit of a characterisation of that. So in this study, I looked at 3 different criteria around stressful life events. And to do that, I used the stressful life event checklist, which is once again just a self-report measure. And based on that, I created 3 different categories. So people in the low category of stressful life events in the last 3 months, so preceding the first rating. So they had no negative life events, or none that were at least on the checklist. Those in the low moderate range, and they had each at least 1 negative event with significant distress associated. And that particular group had a score that fell within the mild depression range on the PHQ9 for standard internalising depression. And then the most interesting group to look at from this perspective were the moderate to high group. And so this is a group that had greater than or equal to 2 negative events in the recent 3 months that had caused them significant distress. And this group fit within the moderate depression group clinical cutoff rating on the PHQ9. So based on that, you can see there's certainly some face validity in these groupings based on standard depression ratings. So as I said, the moderate to high group is the one to keep a particular eye on. But if we think just about getting a bit of a snapshot around what those stressful life events were, you can see here that they were fairly significant events that, death of a first degree relative, job loss, pregnancy termination, major disappointment, serious chronic illness, severe relationship problems, or serious financial difficulty. So they weren't just, kind of mild events. These were quite significant events that were going on in people's lives. So to start with, I'll present the results for the PHQ9, and then I'll show the results for the maldepression scale. So here you can see 3 different graphs. Firstly, at the bottom of the page, looking at the low stressful life events, then middle, low, moderate stressful life events, and then at the top is the moderate to high stressful life events. And you can see that, particularly for the moderate to high stressful life events, there was no difference between the males and females at time 1, but at time 2, there was a trend level difference, or almost a trend level difference, where males were scoring higher on the PHQ9 than for females were. So perhaps there's a bit of an effect of coping there. And if we move on to, I'll move on to the next slide. And so here is where we see the impact of the maldepression scale, where there is a significant interaction, but there's also a simple main effect for gender at both time 1 and both time 2. And so you can see the blue line there that males are on top. And these were fairly large effects, consistent, or sort of moderate to large effects, I suppose. But the emphasis being that there's something kind of characteristically differently going on for males and females in this group that are experiencing significant, or 2 or more significant life events in the recent three months. And the way that males and females are responding to that in terms of their scores on the MDRS, and that's different compared to the low and the low moderate range. So I was kind of interested to see that, because it kind of suggested that there may well be something to this construct of kind of externalizing depression around anger and aggression, risk-taking, substance use as a coping strategy, in particular for males. And so perhaps this is really suggesting that there's something going on in that kind of early phase of distress that may be a precursor to depression, or maybe a particular feature of depression for men in a way that it may not be so much for women. So the other thing that I'm keen to talk about is some new Canadian data so that we've been working on in partnership with the Men's Depression and Suicide Network researchers. So thanks to John and John for making this available. And so just a word of warning, this is so far unpublished data, so things might need to shift a bit as we work it through the peer review process, but still pretty interesting in its own right. So the first slide that I'll show is data from 1,000 Canadian men, so this is part of an online representative sample matched on age and province to the Canadian census. And so the male depression scale was used in this study, so I was really keen to see whether the scale held up in a different sample, in a different national sample, because all the work done that I presented previously was collected within Australia. And so here, this is a slide showing some of the confirmatory factor analysis inventories for the male depression scale, the 22-item version, and you can see that the CFI and the TLI values, which are the kind of main indicators of model fit, were pretty good. They didn't quite hit that 0.95 rating, but often they don't in kind of scale validity research using confirmatory factor analysis. But I was pretty confident and pretty comfortable with those values. But I also tested a competing model, and I didn't include the emotional suppression or the distress subscale, because that was the one that probably had the lowest amount of evidence, kind of supporting evidence backing it up. And by excluding that item, the scale did actually meet those commonly accepted indices. But yeah, other thing to say is that also this study used the PHQ9, and you can see that the MDRS 22 items performed pretty much equivalently, if not marginally better, than did the PHQ9. And PHQ9, as I said, is widely used in a bit of a gold standard self-report measure for internalising depression. So based on that, I was pretty happy with how things are working for the scale, and I think this shows that it is a measure that can be used in context other than Australia, and certainly valid in the Canadian population, and all the other psychometric data in terms of scale reliability and the correlations were all in the right direction and all looked very robust as well. I was also keen to use this study to get some sensitivity and specificity information. So this analysis is based on a ROC curve where I was benchmarking the MDRS, both the 22-item version and the 18-item version, to recent thoughts of self-harm or suicide within the last 2 weeks, which is the final item of the PHQ9. So trying to get a sense of, well, here we can identify a group of men who are clearly at risk if they're having thoughts of suicide or self-harm, and is the MDRS specifically, or is it a suitably sensitive measure to actually detect that particular population? And so a ROC curve analysis considers 2 things: a sensitivity, which is correctly identifying the condition, and specificity, which is correctly identifying the absence of the condition. And based on the stats that came out of that analysis, both the MDRS, the 22-item, and the 18-item were considered to be good at categorising, correctly categorising groups of men into that particular group. That said, it didn't quite hit the excellent range, but I think good is not too bad. And as the field improves, I'm sure measures will kind of be developed and refinements will be made to our scales, and ideally, with future research, we will be able to hit the kind of excellent range. And yeah, so there are the stats there to kind of support that. There was, at least in this sample, an interesting age effect though, and I think it's probably important to note that this was seen both for the subscales of the male depression scale, but also for the PHQ9. So you can see going across the scale, going across the chart here, the younger group tended to have significantly higher scores than the oldest group. So the youngest were kind of in this emerging adulthood, 18 to 25 range, whereas the older group was 66 plus. And many of the comparisons in between were significant, but not all of those post-hoc comparisons were significant. But there was certainly a strong effect between the two bookends of the age distribution. And yeah, it was also seen for the internalising depression as well. So there might be something about this particular stage of life, or there might be a bit of an ageing out effect, especially for the externalising depression features. The next slide looks at some specific questions related to suicide risk. And so the green bars are effectively no answers, and the yellow bar, or the orange, kind of meant to be orange, bars are effectively yes answers to the questions below on the x-axis. So the first question was, in the previous 4 weeks, did you have the thought that you'd be better off dead, or that you had a wish to be dead? And so if we look at scores on the male depression risk scale, those who are indicating yes to that were close to double the range, double the mean rating for those who endorsed no. And that was a fairly consistent pattern across the other questions, which would want to harm yourself, think about suicide, have a suicide plan, and attempt suicide. And you'll note that as you go through, the ends change as people respond to those questions differently. So that final question there, attempt suicide, suicide is a relatively low prevalence event, which is a good thing. But even to have 13 attempt suicide in the last 4 weeks from a sample of 1,000 is relatively high, and certainly of concern. But you can see that those, in terms of face validity for the male depression risk scale, those who are scoring higher are much more likely to have endorsed those items as well. And then if we look across the entire range of the subscales, and I'll just draw your attention to a couple of these points here, there were clear differences, especially for the attempted suicide group in terms of drug use, and that was a very strong effect, and also risk-taking. We're seeing really strong magnitude effects there, and also for want to harm yourself in terms of risk-taking. So I think we can have a fair degree of confidence that these elements of the male depression risk scale around distress, substance use, anger, somatic symptoms, and risk are really suggestive that there can be underlying kind of risk states going on for this sample of men. Whether the same patterns hold for women would be an interesting question, an interesting study in its own right. And I'd be very keen to look at that and do that at some stage in the future. So now we'll start to kind of think about wrapping up. So in terms of implications, a few points to make here. So the presence of externalising depression symptoms is almost certain to hinder recovery from an individual who's experiencing low mood states, and it may even exacerbate co-occurring any sort of prototypic depression symptoms. So there is concern about these, and I think there should be clinical and research attention directed to them. There's also, I think, a significant risk that some of these externalising symptoms around substance use or anger or risk-taking may interact with an underlying impulsivity that an individual might have, and that in turn may indeed escalate suicide risk and also confer other risk relative to health and interpersonal relationships. And I would argue that I think there's probably a pretty good reason why we should be starting to include some of these symptoms in general clinical assessment in primary care settings. And if we were to do that, we might get a little bit more successful in capturing groups of men who might not necessarily be assessed or indicated as meeting risk kind of states through our typical kind of symptom scales, whether it's a PHQ9 or the K10 or other measures that might be used in primary settings. And I think another point to be made is that perhaps there's something about these kind of externalising symptoms that might be a special feature of depression in particularly at-risk men who may meet major depressive disorder presently or might meet it in the future. And as indicated before, this might be kind of an early kind of trajectory indicator that there's something going on for this particular group. So, well, some other things to consider in the kind of when we're assessing and thinking about men with depression, well, we know that initial contact is going to be really critical, so that any first experiences with the mental health system, we need to make sure that they're positive, that we do our very best to engage men from our earliest kind of contacts. And we certainly know that socialisation can impact on presentation. Really important to think about things like anger and aggression in how men are presenting to services and how services respond to those kind of behaviours, and whether they're geared to respond in a kind of a therapeutic way or whether they respond in a punitive way. And there's also an important component of turning our attention to risk assessment as well. And I think also important to think about traits around entitlement, arrogance and narcissism, because I think this is a space where we'll start to see some really interesting work. And I know that David Keeley's done some great work around pathological narcissism and externalising behaviours. So all good things for us to be thinking of. And also I think there's a risk that we can go along the lines of pathologising masculinity without truly understanding some of the strengths and the benefits around masculinity, and so I think a lot more work needs to be done along those lines as well. So in terms of summing up where we are at practice, I think we need to start to move some of these ideas away from the fringe to make sure our science and our methodology and our research is really high quality, so that we can start to get a bit more traction with some of these. And I think we also need to focus on targeted approaches that we engage in with men and boys. And really pleased to say that at least within Australia, the Australian Psychological Association's in the kind of final stages of endorsing some ethical guidelines for working with men and boys. And assessment is part of that, so that there will be consideration that depression can present in alternative ways for men. And also thinking about how we can sway government thinking and policy, so submissions to government, and we're involved in leading some of that work in Australia at the moment. And I think an important point is that we need to work together, and I think international collaborations and partnerships are really critical to that. So any work that we can be doing kind of to leverage the work that we're doing in each of our areas of the globe is a really powerful way to kind of team up and to get momentum going in the field. And so in closing, Will Courtney, one of the main theorisers in the space, a quote from him is that the most powerful men among men are those for whom health and safety are irrelevant. And so if that is to be true, then I think it's important that our assessment and our conceptualisation of men's distress should really start to bear that in mind. So with that, I'll head to my last slide, which is really just saying thank you. And if you're ever in my neck of the woods, which is Australia, don't hesitate to drop me a line. I'd love to see you. I'd love to welcome you to many of the millions of miles of, well, not millions, but hundreds of thousands of kilometres of coastline that we have, complete with kangaroos. So thanks for tuning in, and I guess we'll leave it there. Cool.